Thanks, Emily, and thank you, everybody. I just want to acknowledge that I am very much passionate about what I do, but I am really who I am today professionally for a number of mentors, and some of them include Dr. Duncan, who I had the opportunity to meet, as well as Dr. McLaughlin, who has mentored Emily, and Dr. Narayan, but most of all, the families that I have had the opportunity to work with over the years, and the children have taught me so much. And so I really appreciate, we started today with a fabulous discussion where people who are really living the experience of a family life and a person with cerebral palsy. So thank you. So we had those lived experiences, and then we had Dr. Narayan's lovely presentation about how do we capture those priorities, or what's important about the lived experience, that maybe our interventions can help. And so I'm going to build on this, and you're going to see some replications about some theoretical frameworks about the ICF, but I'm really going to take a dive into what we know about interventions to help kids with cerebral palsy who can walk better. So as a therapist, whether you're a therapist, a mother, a care provider, a surgeon, a developmental pediatrician, rehab medicine doctor, we want to think about what we have in our toolbox. What are the tools in our toolbox that help these children move around, be active, and go out and do what they want to do? So again, my objectives today are consistent with the ICF framework, which you've heard a lot about today, and I'm going to build on as well. I'm going to describe two frameworks that we have in our toolbox as therapists and providers to help children with cerebral palsy walk better. Just very broadly, they're not high-level theories, but it kind of helps us organize our thinking of what we have in our toolbox and whether we should try it or not, and also what we can learn from the research we're doing. The two frameworks really are these two. One is activity-based, which is from the ICF, and it's about task-specific training or motor learning. In other words, if you want to learn how to walk, you practice walking, right? If you want to learn how to ski, you practice skiing. If you want to learn how to ride a bike, you practice riding a bike, right? And then the other framework is from an impairment-based, and that's more on the far side of the ICF framework, where we take a look at what the muscles can do, the range of motion, pain, that kind of thing, the length of the muscles, very much what Dr. Narayan was talking about. If the orthopedic surgeon can get the bones in the right alignment, then the muscles can hopefully work better, and et cetera. And then from a therapist perspective, we want to know if those muscles can then function and perform so that the child can walk. So we're going to take a look at what evidence, and Dr. Narayan talked about levels of evidence, and I'm going to review what we know from research about these two different theories of approach to helping kids walk better. And then we're going to, from that, propose a combined intervention of both of those approaches. And that's called power training with interval treadmill training, or PT cubed. So that's PTTT, or PT cubed. And we're going to describe not just how you implement this in a research setting where you have all the bells and whistles and you have all the expensive equipment, but how you could potentially implement this in a clinical setting. Because I still practice as a clinician, and I'm very passionate about doing research that will hopefully help us with decisions that we need to make tomorrow with the patients and the information that we help parents have so they can make good choices for their children. Then I'm going to briefly describe two regional National Institute of Health studies of Gait training that are task-specific and impairment-based. One of them is power versus strength training, and the other is a home-based treadmill training study. So back to the theoretical framework that we talked about earlier, and thank you to Emily, Kelly, and to Dr. Narayan about just helping us rethink that the health status of persons with cerebral palsy can be explained, hopefully by interactions of all these various factors that we've talked about today. From the literature, this is like a 10,000-foot cliff note summary. We know that children and persons with CP, their muscles do not look like muscles of persons who do not have CP. We also know that their muscles do not function the same way. They're not as strong, they're not as powerful. It's harder for them to elicit them and get them to fire and turn on. We, of course, know that they have trouble walking around their environment, and because they have trouble walking, it's not as efficient, or they can't walk as fast or as often. They have trouble going out into society, into daily life, and doing what they really want to do. And all of that interacts with what environment they live in. Do they live in rural Washington? Do they live on an island off the coast of Alaska? Do they live in northern Canada? Do they live on the southern part of the United States? And also the personal factors of a family. Do you live in a family where they're a very active outdoor family? Do you live in a family that's less active? And then also this is where our treatments, whether it's orthopedic surgery, physical therapy training, orthotics, or whatever, come in, and the dose of what we do as well. So the two frameworks I talked about earlier, the first one is activity-based. That's based on the ICF activity, that middle circle of that framework. That is task-specific. So when I talk about task-specific related to helping to improve walking, it could be a treadmill. It could be body weight supported treadmill training. That's BWSTT. It could be a robot. It could be all kinds of ways, any way to help a child or a person practice walking. Or it could be a body function and impairment-based type of approach. This is the bread and butter of pediatric physical therapy in children with cerebral palsy. We spend a lot of time from day one, the day they're diagnosed, helping address passive range of motion, strength, and etc. So when you simplistically look at those tools in our toolbox, the question is, do we need more practice of walking, or do we have a problem of lacking underlying muscular resources to actually do the walking? So let's take a look at this. So if we think strength training is going to help, we're assuming that if we help the muscle function over here improve, they're stronger, then theoretically, based on this theory or this framework, they're going to walk better. So what do we know about strength training? So this slide describes what happens if the speed of which you're lifting a weight, like say you're lifting a weight with your arm, right? So if you have a really light weight, you can lift it really fast and you can lift it forever. You can just keep going, right? But if you're way over here and lifting a very heavy weight, you can only lift that amount of weight, that really heavy weight, one time. So that circle over on the far right would be considered your one repetition max. In other words, the weight that you could lift or that muscle could generate the force one time. And it's really, and you can't do it very fast. It has to be done very, very slow. So we have a systematic review that was published in our physical therapy literature that looked at the effectiveness of rehab interventions to improve gait speed in children with cerebral palsy. It was a systematic review, which means we went out and looked at all the publications at that time. So this is in 2016. And then we did a meta-analysis, which is a high level way of kind of synthesizing all the information so that we can try to make sense of it in a clinical way. So we looked at all the papers that had to do with strength training in kids with cerebral palsy, and there were a lot of papers. But interestingly enough, the effect size was quite small. In fact, it was almost negligible. It was almost 0.06. Thus, if we looked at that level of evidence, just the evidence in the published literature, there's no high-level evidence that strength training improves walking speed or even other measures of functional walking capacity. But I still, every day, get referrals to strengthen kids post-rhizotomy, post-Semmels, etc. But what about power training? Again, power training is the question that we think if we improve the muscle function of children with cerebral palsy or adults with CP, that will help them walk better. First of all, what is muscle power? Muscle power is really the ability to exert a maximal force in the shortest amount of time as possible. So if I get up from a chair, I get up in milliseconds. I'm exerting the strength and the force in my muscles in a very quick, short amount of time. So think about a 2-year-old with spastic diplegia. They get up from the floor and they bounce up and it happens really, really fast. Now, that same child at age 12 or 22 or 52 will take much longer to get up. And one of the thoughts is that part of that is because they're having difficulty generating the force quick enough to get the job done. Another example where you need muscle power is when you take a step up a stairs. You need to generate that strength quickly to make the step. Exactly. And the same thing with walking on level ground. So it's generating a force as fast as possible. That's the definition of power. So if we go back to that same slide we had earlier, power then is defined by this dotted line, and every striated muscle in your body has a perfect length where it has maximal power. So that's why you arm wrestle with your arm bent at 90 degrees, because that's the best angle for your shoulder muscles and your biceps to work, versus arm wrestling with your elbow out. So if we want to do power training, we're going to be at 40 to 80% of your 1 RM. And that 1 RM is the amount that you can lift just one time. You only have to lift this really heavy amount just one time. Just think of a barbell. You lift it really hard. You could only have to lift it one time. So if we look at the literature, what do we know about contractions of muscles of kids with cerebral palsy? We know if it's an eccentric contraction, that's when the muscle is elongating. The speed, that really doesn't affect what force you can generate. It stays pretty flat. So if you're a slower speed versus a higher speed, so 30 degrees per second versus 120 degrees per second, you can really generate the same amount of force. So that would be like lowering yourself down from a step. But if you are shortening the muscle, so like going from your elbow is straightened to your elbow is bent, that's a concentric contraction. The faster you move, the less amount of force you can generate. And this applies to typically developing people as well as people with cerebral palsy. And this work was documented by a well-known researcher and a mentor of mine, Dr. Damiano, back in the early 2000s. So Dr. Moreau, one of my colleagues, actually went and took a look at the thigh muscle strength. So she took a look at the muscles on the top of the thigh and asked the kids to straighten their knee. She wanted to see how strong kids with cerebral palsy were in their thigh muscles versus children who didn't have cerebral palsy. So she found out if she just looked at what force they could generate or their strength, she found that children with cerebral palsy are functioning at 64% of that of typically developing kids. So they're deficit by 36%. Okay, that's a challenge. We already know. We knew that kids with CP were not as strong as other kids. That's really nothing new. But then she checked their power. So generating the force quickly, or power. When she tested the same children for their power as well as compared to typically developing kids, children with cerebral palsy are actually deficit in power by 82%. So they're actually more deficit in power than they are in strength. So something is dramatically different when you ask them to generate it quickly, or generate the power or the function quickly. So what do we know about power training? Again, if we help the muscle to be more powerful, can that then help walking? So Dr. Moreau did a research study, and what she did is she put children with spastic diplegia on a biodex machine, which allowed us to train the kids in power. In other words, they're lifting and pushing against the pad and training their thigh muscles very, very fast, or velocity training in these children. And at the bottom, you'll see this slide is the cross-sectional area. This is looking at one of your thigh muscles from this down the line of the muscle. And then this is looking at the same muscle from the side. This is your cross-sectional area, and this is your fascicle length. What she found is that the muscle architecture, there were changes. So after the velocity training, this muscle got thicker and bigger. This circle here, you see the circle was bigger, and this was thicker, and this angle changed as well. But what she also saw when she did the power training and the velocity training is she saw improvement in walking. Now, she was not expecting improvement in walking because all the research had said that strength training did not improve walking, but she did see a change in walking speed. So she saw an increase in the rectus femoris, which is one of those thigh muscles we were talking about. The cross-sectional area got bigger, and the fascicle length got bigger as well after 8 weeks of velocity training with knee extensor power. And the most exciting part is she also saw increase in walking speed, and the patients reported changes in their functional mobility in daily life. So at the moment, there appears that muscle power may be a key ingredient for walking ability and performance. In other words, what you can do in a clinic versus what you can do in daily life. Capacity would be what you could do in a clinic under a setup situation, maybe by a therapist or a physician asks you to walk. And performance is really what you do in daily life, in the context of daily life. And other functional activities such as transfers, getting up from the floor, walking on stairs. And it appears from the literature anyway, and that there are improvements in strength alone do not always translate into improvements in walking. And let me make it really clear, all of those studies that we looked at about strength training, all the kids got stronger. They all were able to lift more weight at the end. But what did not happen is with that increase in strength, we did not see a change in their walking speed that was always consistent. We're going to talk about that a little bit more. So back to our toolbox, what do we do? So do they need more practice? Do we work on their strength? Do we work on range of motion? What do we do? Or, we're getting mixed messages here. What do we do? So what do we know about the tools in our toolbox about treadmill training? Again, treadmill training is coming at it from a practice perspective. If we practice walking, will that help them walk better out in the community? If we practice in therapy, will they be able to walk better at school, playing soccer, etc.? So again, this is part of our systematic review that was published in 2016. We took a look at all gait training that was published in kids with cerebral palsy, and there was a lot. So we included certain studies, and they had to meet a certain criteria. This included treadmill training, this included overground training, it included body weight support, and robotic training. So what was exciting is we saw effect sizes of 0.75 to 0.92, which were significant if you're into p-values. And how we would interpret that would be considered a moderate to a large effect size. So from a research perspective, that says that this is a big enough effect that we could really see this. This is something that would be meaningful. So when we looked at the 8 studies that we studied or analyzed, only 4 of the studies, though, had a change in gait speed that was greater than the MCID. So we heard about this earlier today in Dr. Narayan's presentation, and a question, MCID being minimally clinically important difference. And what we know about gait speed is this has been previously established for kids who walk with cerebral palsy. The MCID is 0.1 meters per second. So half of those studies did not, the kids were walking faster, but it wasn't fast enough for it to really be clinically meaningful. And I often describe clinically meaningful as also such that I don't have to go to a gait lab, or I don't have to necessarily put on a stopwatch to be able to see or observe that I'm seeing this kid walking faster, or the mom is seeing the kid walk faster, or the kid reports that they're walking faster. So then we took a look at the gait training ways where you gave body weight support, BWS, or without body weight support. And we saw 2 different effect sizes. We saw some variation. So for body weight support, so that would be like we hold a kid up with a harness while they're on a treadmill, or like a robot or whatever. We actually saw a study where the effect size went negative to quite large, 0.82 in 5 of the studies, which is exciting. But when we looked at without body weight support, the effect sizes were multiple times bigger. They were 1.32 to 3.2 in 3 studies. Now, it was only 3 studies, but those effect sizes were very, very large. So if we think about what we've done with treadmill training and body weight support training and gait training, a lot of the research in kids with cerebral palsy has been based on what has been done with adults who need gait training. And this could be someone with a spinal cord injury, it could be an adult after a stroke, it could be adult after a head injury. So if we look at the adult protocols and adult literature, there's been some very large $10 million research studies funded by the NIH that have looked at treadmill training in adults post-CVA. And what they used for the protocol and how they trained them was they put the person on the treadmill with body weight support or not, and they would walk at a speed. And then if they could walk that speed for 30 minutes, then the next time they got them on the treadmill, they would walk them at a little bit faster speed. So it was very much an endurance-based approach. In other words, walking longer and at a faster and faster speed within the sessions. But what they found from that research generally, this is just an overview, is that body weight support and robotic training in adults actually decrease muscle activation. Okay, so that may not be what we really want. So if that's what they learned from adults, the question of is that appropriate for children? And is that appropriate for children with cerebral palsy? So what I want you to think about is all of you think back to when you've been around toddlers and or younger children on an elementary school playground or whatever. And when you watch them move and walk, they, throughout the hours of the day, have periods where they're way up and they're moving really, really fast. And then they have periods of the day where they're really not moving very fast. And they're at medium, low, high, low. And this is normal development. In fact, it's expected that a toddler, a new emerging walker, will go up, 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 walk, 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 fall, up, walk, 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 fall. So this is actually normal development. And this pattern of activity can switch as frequently as every 2 or 3 seconds, or every minute, or every 10 seconds. So, and this pattern actually persists up until about age 14, when you start moving more like an adult in your movement patterns. Now, this is typically developing children. We know from research that we've done with pedometers and other physical activity devices and worn monitors that children with cerebral palsy have a very different pattern. They spend most of their time in low activity, sometimes get up to moderate, and the really high functioning kids might get up to high once in a while. But this sort of fits with what we know about kids with cerebral palsy. They have difficulty keeping up or ramping up to higher intensity levels of walking compared to their peers. And thus it makes it challenging sometimes for them to play soccer or to do some of the things that their friends are doing. If we compare this pattern to adults, you and I, unless we're out training for a marathon or specifically training with interval training, we are very efficient. We choose one level, and from point A to point B, we pretty much stay at a pretty steady state. And this is because we have found with our mature body and our size, what is kind of our level of activity and what intensity level we'll use. Some of us are faster walkers than others, but we're all pretty flat throughout the day. And when you put a person on a body weight supported treadmill, which is what we did in the adult literature, we basically are asking them to walk at a steady state, but just a little higher and a little faster. So that's what was done in the literature before. So when you think about how we look at our kids that we work with, the children with cerebral palsy have difficulty kind of ramping up their walking intensity to high and moderate levels, like, for example, running to first base in baseball or catching a pass to receive a pass in soccer or whatever. So we wonder if muscle power generation is significantly impaired in kids with cerebral palsy, which we saw that they're 82% less than typically developing kids. Is it really muscle power that is one of the underlying resources that is lacking? So what Dr. Moreau and I have come together to do is we're proposing that there's a combination intervention that might be helpful for children with cerebral palsy to help them walk better. And we suggest that we put task-specific or action-based intervention, so practice the walking, and the impairment-based, improve strength or power. And we put that all together into something called power training and interval treadmill training, or PT cubed. So the premise behind PT cubed is that combining an impairment and a task-specific approach, so underlying muscle problem and practice what you want to learn, approach that is developmentally appropriate. In other words, train children to walk like children, because children walk in short bursts, walk slow, walk fast, slow, and then target the muscles of power deficit specifically is necessary to drive changes in clinic and community-based walking activity. We believe that this could be innovative from current rehab, because current rehab is we put kids on a treadmill and walk them at a steady state, and our current rehab strategies as we do a lot of weightlifting and we get kids stronger, but that doesn't always carry over to helping them walk. We think this could have an impact on the field of rehab. So also the cool thing about this is something that's clinically feasible and cost effective, because most centers can do power training, most centers can do treadmill training, or it can even be done in the home. So when we do resistance training, this is just an overview. The therapists on the call today or the conference today will see that this is a no-brainer, because if you want to improve walking, what muscles are we going to need to train specifically? We want to train the thigh front muscles or the quadricep muscles, because there's 4 muscles there. We want to train the calf muscles or the gastroc and the gastroc soleus. And we want to train the hip muscles, the larger hip extensor and the one that keeps the hip from dropping. So as you see, this person with cerebral palsy walking one hip likes to drop down, and that's because the muscle on this side, on the outside of the hip, isn't as strong or maybe as powerful as it should be. So if we go to the Academy of Sports Medicine, and you talk about strength training versus power training, this applies to persons with cerebral palsy the same way it would apply to you or I. If we were to go to the gym, or now that we don't go to the gym because of COVID, we're training at home. If you look at it, muscle strengthening entails high resistance, and power training is high resistance but a high speed. They're similar in frequency. They suggest that you should train 3 times a week, but not consecutive days. So you want to have a rest break of at least 24 hours between your training. You need to have rest between the sets, so you just don't keep lifting after each set, but you take a little break in between. And a minimum of 8 weeks of this type of frequency of dose of training is what you need to get a change in strength or power. Now, what's different between strength training and power training is in strength training, we're at 60 to greater than or equal to 85% of the 1 rep max. That's for strength training. And what you do is you do lots of reps at a lower weight. So you can do them fairly slowly. You can do 3 sets of 12 reps. So lots of reps, but you do them at a slow or moderate controlled concentric and eccentric contraction. So that means slowly up and slowly down. 1 to 2, 3 seconds up, 1 to 3 seconds down. Power training, in contrast, you're at 40 to greater than 80% of your 1 rep max. And you're going to do only 6 sets of 5 reps, because this is what you're asking to do in power training, is you're asking to do it as fast as you possibly can. So this would be a push really fast up in milliseconds and then come down slowly. So it would be very much a fast contraction of the muscle and then relax eccentrically to come down. So how do you do this in a clinical setting if you don't have a Biodex machine? So for those of us who don't have a Biodex machine or a velocity training machine in our back pocket, which most pediatric centers don't have, you can do this in a clinical setting by using bilateral and unilateral lower extremity squats in a variety of ways. For example, for a child who's very weak or on the weaker end or just progressing, you could start supine on a scooter board with gravity eliminated and you push off the wall. You can make it into a game. You can do supine scooter board up a ramp with weights, like in that picture. You can then add weights and increase as their strength improves. You can use a supine stander and do squats on a supine stander, starting in supine, which would look like this. And then you increase the degree against gravity as they get stronger. Then once they're vertical, then you put them on against a wall. So they're doing wall squats. So for you skiers on the call, this is no different than getting ready for ski season when you want to work on wall squats. You slide up and down the wall with some way of having that friction decrease, and then you put weights either on their shoulders or on their weights in their trunk. If you have a high-tech access, so something such as a Biodex machine is very much set up with quadricep extensor work. You can also do hamstring work. You can also do hip extensor work, and that looks like this. You could also use a tool called the Total Gym. And the Total Gym is the same device that you've seen Chuck Norris and on the infomercials for sale for years. And there's home versions that I've had many families use in the home. And we have a professional version for our research study, but I also have a number of clinics, physical therapy clinics, that have them as well. What's really nice about the Total Gym is you can train a child who's a GMFCS level 3, who is just barely walking after a SEMO on a Total Gym, to a child who's very, very high functioning, GMFCS level 1, lifting 600 pounds of plate weights. In fact, we have a child in our research study we have a child that is training at a lower level on the Total Gym, and then now has moved up to a higher level as they've increased their strength and their power. And the same thing is then you add plate weights to the Total Gym. So this is what it looks like. If you put a child on a Total Gym, this is a professional version of the Total Gym, and this picture is from LSU. This is a young man with spastic diplegia, and you can tell he has spastic diplegia because he has really tight heel cords. But having tight heel cords doesn't preclude him from doing this training, or tight hamstrings. So we would ask him, if this was power training, to push, lift as fast as possible, push, and then slowly come down slowly. And we would have that set up in the number of sets if he was in power training versus strength training. So would you please play the video on this slide? So AB is going. So what you see here is I am showing you a side view of a child who is on a treadmill going fast. And now you can see the transition to slow here in a second. And I will tell you, my standing behind the child would not be the normal way that I would support this child in treadmill training. The only reason I'm doing it for you is to show the speed change. And I'm also showing you how nicely his heel-toe pattern is and the opportunity for mass practice. So now I'm switching him. I switch him fast from slow to fast.
You are so fascinating.
And as you can tell, his twin brother is not too excited about the whole idea. But this young man at age 5 was walking at a speed of like 3.2 miles per hour. So you really were able to challenge them at the ceiling of their walking performance. And that's exactly what you're trying to do in short burst interval locomotor treadmill training.
5, 4,
Could you please stop that video? Go to the next slide, please. So on this slide, please show this slide. This is an example of an older young lady, also doing short burst locomotor treadmill training without orthotics on. And what you'll see here is that she's actually hanging onto the side handrails. And you'll see her transition from a fast speed to a slow speed. And again, we use the same protocol of switching quickly. And what we're trying to train is one, using faster speeds for short bursts of time, because that matches how children walk. And also one of the things we're trying to work on as well is we want to make sure that we're training them to walk such that their posture is over their feet. So one of the reasons this child is using her handrails is we want to make sure that her shoulders and her head are over her feet as she walks. Great, thank you. You can stop that video and I will reshare my slides. Could I have share control back? Thank you.
Yep.
There we go. Little technical. Come back to the slides here. Okay, we're moving along. Okay, so we look at these two slides. So let me tell you about two studies that are funded by the National Institute of Health, in other words, our tax dollars in the United States, to optimize walking in children with cerebral palsy. And both of these studies are being conducted at Seattle Children's Hospital, collaboratively also with LSU Health Sciences in New Orleans. One of them is PT-Cubed, which you've heard a little bit about already, and the other is SBLTT. So there's a lot of acronyms there, and I will explain all of those to you. So the first study is power training with interval treadmill training, or PT-Cubed, to improve walking activity and cerebral palsy. And the primary investigator for that is Dr. Noelle Moreau, who is a physical therapist who has done lots of work around power training, as you've heard me talk about some of her work, but also has done a lot of work documenting outcomes at a muscle level, particularly with ultrasound, the ability of the muscle to generate force and power, and also looking at functional outcome. Our local Seattle study team includes myself, Shanir Sadang, as well as we have physical therapist City and Jill Lehman, who are helping us with assessments and intervention. And we also have a collaborator from the University of Washington, Phil Hurwitz. And one of the things that Phil is helping us with is we are actually putting pedometers on these children with GPS, so we know when they're walking and we also know where they're walking. One of the things that this study team helps us with as well is one of the outcome measures of this study is we're doing patient-reported outcome measures. And one of those is an outcome measure that you're going to learn more about with Dr. Narayan in his next presentation. So the premise is similar to what we just shared earlier, that we believe that if you combine impairment and task-specific approach to a developmental approach, in other words, train kids to walk like children, and we target the specific muscles, that will drive changes in clinic and community-based walking. We hope to enroll over our 5 years of the study, which will probably end up being 6 years because of COVID. We hope to enroll between New Orleans and Seattle 48 children with cerebral palsy that can walk. Half the children will get PT-Cubed, and the other half will get a total gym training, strength training program, and treadmill training as well. So both groups get training. And then we bring them in 8 weeks after for a follow-up, and then we do 2 months later and then 6 months later to see if any changes last longer than 2 months afterwards. So the children that get power training, or PT-Cubed, will do power training on the total gym. They'll do bilateral squats and unilateral squats with a power training emphasis, and then they will go to a treadmill immediately afterwards and do short burst interval locomotor treadmill training. The children in the control or comparison intervention will get strength training on the total gym. So they're lifting weights in the total gym too, but they're using a strength training protocol. And then we put them on a treadmill immediately afterwards, and they will do traditional locomotor treadmill training, which means they're walking at a steady state. Both groups get 24 sessions delivered 3 times a week for 8 weeks on non-consecutive days. Now, to be in this study, we are looking for children between the ages of 10 and less than 18 years who have a primary diagnosis of bilateral spastic cerebral palsy. They can have a little dystonia, but we'd like them to have predominantly spasticity. And these are kids that walk with or without assisted device. So we have kids who walk totally independently to children who use handheld devices like canes and walkers participate in the study and do quite well. So the other study is short burst interval treadmill training to improve community walking activity and mobility in cerebral palsy. And that's what the word SBLTT stands for in this acronym. SBLTT is short burst locomotor treadmill training. We are co-investigators together, Dr. Noel Moreau and myself. And again, we're doing this work in Seattle and New Orleans, or Nolens, if I were correctly to say that. For somebody corrected me yesterday when I said New Orleans. I should be saying Nolens. So the assumption with SBLTT is that we know that there's muscle power limitations in kids with cerebral palsy. We know they don't walk as many steps per day. We also know that when they do walk, they don't walk at high stride rates. And we know they have trouble with community mobility. So we propose that SBLTT, or this home-based treadmill training of short burst interval, will be fast walking that is practicing the task of learning to walk faster and transitioning from slow to fast. And that it's that fast walking that's going to help the muscles generate power at high intensity walking. We believe that that is going to increase self-selected and fast walking speed, the number of strides they take per day, and when they do walk, they're going to walk at higher stride rates. We think that in turn will help them walk more in the community, and we're going to be using patient-reported outcome measures of mobility, their gait priorities, using a tool that Dr. Narayan will be talking about in a few minutes, and about their quality of their gait. We believe that's all going to be impacted by their generating of power during those short bursts of walking fast. So the kids in the SPLTT versus the traditional locomotor treadmill training, that's what TLTT stands for. The kids who get SPLTT are going to get short burst interval locomotor treadmill training. And that means for 30 seconds, they're at a high speed. And then we alternate that with 30 seconds of a low speed. And we increase the high speed within the session and between the sessions. So the high speed gets faster, faster, and faster and faster until they're training at their ceiling. And then we leave the slow speed stays the same through all the sessions. In traditional locomotor treadmill training, that consists of walking at a steady state for 30 minutes. And then after they can walk at that speed for 30 minutes, then we increase it at the next session. And all of them will get, all the kids will get this treadmill training in their home for 40 sessions. Both groups get 40 sessions delivered 5 times a week for 8 weeks. So it's an opportunity for a burst of gait training in the home. And with that said, we're going to hopefully enroll 72 subjects between Seattle and Nolens. And there'll be 36 kids that will get SBLTT first. Then they'll come in after 20 sessions for testing, and then again after 40 sessions. And then another 36 kids will get traditional locomotor treadmill training. After 20 sessions, they come in for a test, and again after 40 sessions. And then we follow them up 6 months later to see how they're doing. So I want to say the only way this project really works is we have a fabulous team of almost 20 clinicians, interventionists that we have trained in the community to actually give this intervention. And all of these people have committed their time and energy and have been trained to implement this intervention. And they are led by our extraordinary research coordinator, Neil Panalasagliwi. So thank you to all of the therapists. I won't list them all, but I want to acknowledge that this work is really a community-based intervention that's happening in the home. And it really is happening because these people are dedicated and have taken the time and effort to make this happen. So for a child to be an SBLTT trial at the moment in Seattle, you need to be between the ages of 6 and less than 11 years, have a primary diagnosis of bilateral spastic diplegia or cerebral palsy. And these children need to be at GMFCS level classification level of 2 and 3. So that means children that are walking on level surfaces pretty comfortably, but when they go up stairwells, they probably hang onto a railing or go up and down hanging onto a railing or need to it when nobody's looking, or they're walking with a handheld device pretty functionally around their environment, maybe a wheelchair for long distances. So in summary, youth with cerebral palsy are more deficit in power generation than strength as compared to typically developing kids. There is no high-level evidence, at least published to date, that strength improvement alone translates and does not translate into increased walking speed or function. There's very low-level evidence, though, that muscle architectural changes specific to power and velocity changing training, or in other words, that the muscles got bigger, was also related to improved walking. And that work is primarily the work, our pilot data that Dr. Narode published, and also we have published within our R21 of that study. So this has clinical implications to optimize functional walking. This is for gait training at any point of care, but also post-surgical rehab. So some of this information has potential for how we progress gait training after a surgical procedure, such as an SEMLS, which is an acronym that stands for Single Event Multi-Level Surgery, which is where we combine a number of orthopedic surgeries into one surgery and to try to limit the number of times that the child has to go to surgery. And Dr. Narayan will be talking a little bit more about that as well. Or SDR, which is selective dorsal rhizotomy, which is a permanent treatment for velocity-dependent spasticity, and particularly in the lower extremities. So just remember, muscle power is possibly a key ingredient for walking capacity and performance and other functional tasks that require the movement to be done quickly, such as transfers, stairs, and out in the community playing sports. I just want to acknowledge that if anybody wants to learn more about that, please contact myself, Neil, or Shanir here in Seattle. And then I also want to acknowledge that it is our tax dollars that are funding our work right now through the NICHD NCMMRR, which is the National Center for Medical Rehabilitation Research. I hope you guys feel that this is dollars well spent, and I'll open it up for questions at this time. Thank you. Should I stop sharing?
Yes, I will take over. So just give me a second. And we have time for a few questions here. If you, below your Vimeo player, there is a QR code or a link to the Menti poll if any of the folks watching and listening want to submit their questions. I have a couple of questions for you, Chrissy. Give me 1 second.
Sure.
All right, so our first question, it seems like the low-tech ideas can work with children who are fairly young. What were the ages for the people in the studies, and what is the youngest you would suggest?
Great questions. So the low-tech ideas, yes, work very well for kids who are young, but I've also have colleagues who have done some of the low-tech ideas like the wall sits and the progressive wall sits. I've seen that work for adolescents and high school age kids as well. So of those two studies, the youngest in the study is 6, but I have done treadmill training kids as young as 18 months. So clinically myself. So it really, it's individualized. So the treadmill training, I just last week worked with a couple of my colleagues who are training 3- and 4-year-olds, and they're doing quite well and has some really nice changes in walking speed and balance, and that all interacts with what orthotics they're wearing, particularly for the young children. And also the orthotics can play a big part in the older children being able to do treadmill training. One thing I will say is an older child, if they don't have a stable stance phase on one side, they don't have a stable leg to stand on literally in order to take a fast step. So they don't even have a fast speed. I had a child come in who wanted to be in one of our studies, and without orthotics, the child couldn't even walk fast. They didn't have a fast walking speed because their stance phase was so unstable. So that suggested that maybe an orthotic or a type of orthotic would have given that child some more support. So that's something to think about. So I hope that answers your question.
All right, our next question. In typical muscles, strength and power need to be supported by working on it. Was there any research to determine if CP muscles needed to continue with the weight training to maintain the gains?
That's a good question. That second question about do they need to keep doing the weight training to maintain the gains? No, that has not been formally done to my knowledge, which is sort of part of what's going on with some of the research that we're going to do with the 6-month follow-up. I can tell you clinically, I have children who have continued type of power training in their therapy after they finished being in the protocol, and those children just anecdotally seem to be doing well and maintaining or even progressing farther. So I would guess it'd be fairly similar to you and I. We need to stay in shape to get the job done. And I would think persons with CP, adolescents, particularly since they're growing, would also need to be probably in better shape than you and I, more powerful, more strong than typically developing children to get the job done. But good question. No, to my knowledge, there is no answer to that question published to my knowledge. Good question.
One question from one of our panelists. Could you speak about the orthotics and shoe modifications for kids and how that helps mobility?
Oh, that's an interesting question. Actually, I just finished a protocol where we actually add an R21, which is a pilot study from the NIH. And we have found that if you're going to train a child on a treadmill, you want them in as optimal biomechanical alignment. In other words, you want the segments of their legs aligned as optimally as possible with their orthotics. And there's a belief that shoe modifications and getting the shank, the vertical angle, and the lower extremity bones in the appropriate alignment make it easier to take a stride, a stable step, which I alluded to earlier. So in my experience, kids can walk faster with that type of alignment versus not having that type of alignment. And getting that alignment is all individualized. So it may be using the Elaine Owens approach or it may not. It just depends on the type of orthotic and the physical exam of the child and whether they've had a rhizotomy, a semel, whatever. There's all kinds of things that go into that. But having them optimally align and then doing the treadmill training, at least for my clinical anecdotal experience, appears to be helpful. At least they can take a faster step.
All right, we have a question about when are the studies starting?
That's a good question. Both of these studies are going now. They're active right now. In fact, one is the PT3 grant is actually just finishing its third year, and the SBLTT grant is finishing its second year. But I'm guessing both of those studies, they're 5-year studies. I'm guessing they will end up being 6-year studies because we lost some time for enrolling because of COVID. Both of those studies are both enrolling during COVID. And what we do is we carry out all the COVID precautions that are consistent with the CDC and what Seattle Children's requires for you. If you were to come into Seattle Children's for an outpatient physical therapy visit, we replicate those for coming to our site to do the training for the PT3 study. And when we do the home visits, when a therapist comes to a child's home, we bring the treadmill to the home, we bring the therapist to the home. Every time you come to the home, we go through the same attestation and temperature check and everything as if you were coming for an outpatient visit at Seattle Children's. So all these studies are occurring right now. So if you have anybody who's interested or a family, send them our way, please.
This is a question. My daughter is 24 and she has been using walkers, Bronco now. She is with Gait trainer. Do you have any trainer or recommendation to continue services?
Oh, that's a great question. I'm not sure exactly where you live, but I have seen older young adult persons with CP who are doing some assisted walking do well with maybe a burst of outpatient therapy. And there are several providers in Western Washington that can do that outside of Seattle Children's. Not Seattle Children's does not see persons over 21 generally for outpatient therapy, but there are facilities that do outpatient intense births, and you could explore changing the type of walker or the type of training or whatever to see if you could move your child or your young adult daughter along to whatever her goals or your family's goals are for her. So there's a question that asks, for the SBLTT protocol, what is the total time per session that you are on the treadmill? You are actually walking on the treadmill. The treadmill is moving, the tread is moving 30 minutes for each session. I hope that answers that question. But you are allowed to have rests. And with rests, the whole training session has to be done in 35 minutes.
More questions here. Have you done power work targeting the trunk muscles, and if so, does this affect walking speed and function?
Oh, that's a great question.
I personally have not done it, but I do have some colleagues on the East Coast who are exploring trunk training. That it hasn't been specifically a muscle power training of the trunk, but I think that would be really interesting to explore. And also thinking about ways to actually do it. You know, are you going to do gravity eliminated? Are you going to do it in sitting? Are you going to do it in standing? Are you going to do it in walking? That's a great idea. To my knowledge, it has not been done, but I do know they've been doing some with persons with cerebral palsy who are really functioning at GMFCS level 4s and 5s. And if that person is interested, please have them email me and I can connect you with my colleague on the East Coast who's been doing some of that work.
Next question, is working on jumping for higher level kids a good idea to work on power?
Yes, totally. That's an example, totally a great example of a clinical tool in your toolbox. It could be jumping up steps, jumping up to a box, jumping down from a box. It could be putting a waist belt on them and they're dragging a tire and you ask them to go faster and faster. I maybe have heard about the beep tests that kids do for functional training in PE. I know colleagues in the Netherlands who have done totally a low-tech approach to power training without even a supine board or whatever. And they've done dragging quickly, running quickly, up and down stairs, up and down ramps. All of that is another way that you can treat the lower extremity muscles, and or you're going to also treat the trunk muscles as well for power training. That's a good question. Yeah, please share if you guys have ideas. That'd be great.
All right. Your research studies include children with spastic diplegia. Would you apply the same type of training to children with asymmetrical involvement, like hemiplegia? And happy birthday. I didn't know it was your birthday.
Yeah, thank you. Yes. So kids with hemiplegia, one of the things that we want to do, obviously, with kids with hemiplegia is because their gait is asymmetrical. And I've had really good experience on a clinical perspective with appropriate orthotics approach of putting them on treadmills, particularly kids that are the lower functioning children with hemiplegia do quite well on treadmill training. They're already walking pretty fast, but what you're really trying to work on is getting more symmetry. And if you can get them walking with longer and longer strides, which they have to do to walk faster, you're going to dynamically lengthen, at least theoretically, dynamically lengthen the hamstrings and increase their use of knee extension at the appropriate times during terminal stance and initial contact and stance phase. So yes, you can totally do it. In fact, one of my trials with orthotics, our next grant is going to be combining kids with hemiplegia and diplegia with orthotics on treadmills for toddlers who are just learning to walk. Good question.
We'll have to celebrate after, Christy.
Thanks.
Do you have any information about the longevity or the sustainability of the outcome?
I don't have formal data other than we published the pilot data from the SBLTT study. I was the first author. It's in disability and rehab, and that was just 12 kids, and it was pre-post, and everybody got short burst locomotive treadmill training. Some kids got it 5 days a week, and some kids got it 2 days a week, and they got it for a total of 20 sessions. And we saw sustained improved community walking and the amount of community walking out to 6 weeks. But at 6 weeks, it was starting to go down back to baseline. It was still significantly better. And it appeared to be clinically meaningful at that point as well, but it was starting to go away. So that's why in that study, we dosed 20 sessions. And now in this study, we've doubled the dose to 40 sessions. So that's a really good question. So that's one of the things we want to find out is that's a lot of training to put kids through. And is it worth it? And how long does it last? And then, of course, the next question will be is if this is helpful and it lasts for 6 months, how long does it last? And do we need to do it again in 2 years, in 1 year? Is this a protocol we should use after a SEMLS? Is this a protocol we could use after a rhizotomy to help move kids along faster? Those are all questions that beg to be done, for work to be done.
Absolutely, more work to be done. And then what is your feeling about the effect of push-off and gait training when wearing orthotics with stiff plastic forefoot?
Oh, good question. Well, if you've locked the ankle up and you've also locked the forefoot, you've probably locked it to protect the midfoot. The midfoot's pronating in a device. So what you really done is it's the momentum of the limb and the body moving forward versus it coming from a propulsive push-off. And actually, this would be a question for Dr. Narayan because he's got a lot more background in gait analysis than I do. But if I can get a child kinematically to be able to control the knee and hip and look great across all phases of gait and be efficient and then move to a flexible forefoot and protect the midfoot in the device until they're old enough, then I think it's great that they should have a flexible forefoot and have that improved third rocker or bending of the forefoot as the heel comes off. I hope that answers your question. Or maybe Dr. Narayan wants to jump in.
Yeah, I think we could save that question for Dr. Narayan as well. Can community therapists follow same power training, and how often would it be truly effective? Can you do combo of training total gym in clinic and standard at home?
Oh, good question. So my experience personally is what I've done is I've trained the family to do the treadmill training at home. Some families have done it, mom or dad does it with the child, or they have acquired volunteers who want to come into the home to help them do it. So that's the short version of a locomotive treadmill training. The power training, as in wall sits and squats and stuff like that, you can start that totally in a PT session, and then it can be carried out at home depending upon how you set it up. And then also another way in the community is to work with athletic trainers who are comfortable working with persons who are non-typically developing, and there are never trainers that some of the kids I work with, and they do power training when they were able to go to fitness gyms. And now in the state of Washington, those are opening up again. So that's something to look at. So yes, it can be done. And I'd be happy to problem solve that with you. If somebody wants to email me later and we can talk, brainstorm about that. But yes, I have had good experience with that being translated. Good questions.
Thank you, Christy. And can you give details about warm up and cool down before and after each treadmill session?
That's a good question. So we require, we actually require a 5-minute walk-up, warm-up of walking, just regular self-paced walking before the total gym or the power training. So that part. But when it comes to the treadmill, our protocol for both of those is to have a 5-minute warm-up and a 5-minute cool down. And one of the things you really don't want these kids to do is to just go ahead and sit down right after they've got their muscles nice and warm. The other thing I will say is these kids, if we are challenging them in either protocol, whether they're getting traditional treadmill training or SBLTT, these kids should be getting hot and sweaty. They should be exercising. They should be pink. And so you want to cool down, and it's usually generally walking or braiding or walking backwards, sidestepping at the wall. I've had one kid do crab walking. One of the things we don't do in our protocols, we don't do hopping on a therapy or sitting on a therapy ball and bouncing, and we don't do hopping on a trampoline or climbing up and down stairs, because those activities actually are propulsive and are probably affecting their continued power training. So we don't do those in our protocol, but you could do them in the community if that wasn't a concern of yours. If the kids could do them after training for 30 minutes. Good question.
One last question here. How can the audience get diagrams on how to do power training versus strength training?
I'm guessing you're asking about the decision tree of how to do it. Dr. Moreau and I are in the process of actually publishing it. So it will be published hopefully soon. The other is I'd be happy to share it with you. Since it hasn't been formally published, we want to make sure that if it goes out into the world and people start using it, they don't reference it as actually doing this protocol unless we know you're really doing that protocol or you've been trained in it or whatever. So please email me and I'll be happy to follow up with that information for you.